Hello, everyone, and welcome to UNSHAME Kentucky's July webinar, Minding Your Bedside Manner, Caring for Patients with Opioid Use Disorder. My name is Michelle Juma, Project Management Specialist at Shatterproof and coordinator of the UNSHAME Kentucky webinar series. And we have a fantastic 60-minute event for you, so please feel free to put your name, your organization, your location in the chat box. We'd love to see who's with us today. To go over some housekeeping, this event is being recorded and will be available on the UNSHAME Kentucky events page along with a copy of the presentation. All attendees will be muted throughout the session, but please use the Q&A feature at the bottom of your screen, and we will be able to go through those questions at the portion later on in our event. The chat is also available for general commentary, but we won't be moderating it as closely. As you can see, our interpreters will remain spotlighted on screen, but if you're having trouble viewing the other presenters, I suggest you change your view to gallery or side-by-side view by clicking the view button at the top right corner of your screen. Closed captioning is also available by selecting the closed caption button towards the bottom of your screen. This would also be near the Q&A feature. The UNSHAME Kentucky webinar series is brought to you in partnership with the Kentucky Opioid Response Effort and Shatterproof, and a special thanks to Kentucky Office of Vocational Rehabilitation for providing ASL interpreting services for this event and all future webinars in the UNSHAME Kentucky webinar series. This specific event is also held in partnership with Kentucky Hospital Association and the Kentucky Statewide Opioid Stewardship Program. These initiatives focus on reducing opioid overprescribing, improving safe opioid use, and providing a mechanism for hospitals to demonstrate their actions and commitments to their patients and communities to combat the state's opioid epidemic. I'm going to pass it over to my colleague, Marissa Williams, to do a quick overview of the UNSHAME Kentucky campaign, and then we will begin a presentation from another Shatterproof colleague before we begin our panel discussion. As you close out of today's event, a survey will appear on screen, and we please ask you take the time to complete it. And we're hoping to always improve this webinar series and increase our offerings for any interested parties. Marissa, welcome to come forward.
Thanks, Michelle. Thank you all for joining us today and supporting UNSHAME Kentucky. I'm just going to give a brief campaign overview for those of you that aren't familiar with our campaign. So UNSHAME Kentucky is a 12-month-long addiction stigma reduction campaign. Like Michelle mentioned, it is sponsored by Shatterproof in partnership with the Kentucky Opioid Response Effort, or CORE. Our campaign started in March of this year. Moving on to some of our main goals of the campaign.
Yeah, big time focused in supply chain.
So our goals of the campaign are to increase knowledge about OUD and share with Kentuckians all across the state that recovery is not only possible, but probable with proper support from friends, family, and their community. We also hope to improve attitudes towards those living with or are in recovery from OUD. And finally, we really want to develop Kentuckians' understanding of the disease of opioid use disorder, so people can better support loved ones with OUD. So moving on to our evidence-based approach. So we really have three main pillars of the UNSHAME campaign. The first being community connection. So we spent the first 3 months prior to the campaign launching, just connecting with community organizations across the state to really understand what stigma looks like in different parts of the state. We also have a community impact committee. So this is 8 members of people that went through an interview process, and they're representing all of these different communities across the state of Kentucky. Next, we have story sharing. I would consider story sharing really the main pillar of our stigma reduction initiative. So we collect stories from people in recovery, friends and family of people with OUD or in recovery from OUD, as well as those that may have been lost to overdose, as well as a few stories from people that work in recovery or treatment services. This really helps people that maybe don't have that personal one-on-one connection with someone with OUD. It helps them create that connection and build a bridge to really understand what this disease is. And finally, education. So why you all are here with us today. We leverage our community-based organization networks to spread that anti-stigma messaging to their networks, as well as provide monthly webinars that I hope to see you all at in the future to really gain knowledge on what OUD looks like. Now I will hand it over to my colleague, Rachael Cooper.
All right, well, thank you, everybody. I really appreciate you being here today. Happy to be talking to the communities in Kentucky. I think that this is a really excellent opportunity to collaborate and share a little bit about addiction stigma and healthcare, how it manifests, and some of the actions that we can take. So like Marissa said, my name is Rachael Cooper. I am the Senior Director here of the National Stigma Initiative at Shatterproof. I've been with Shatterproof for almost 1.5 years at this point. My primary responsibilities focus on reducing addiction stigma amongst healthcare professionals. So very excited to be here with you today, like I said. So what we're going to do here is really just some level setting. I think it's important that we all have the same definition of stigma in our brain, understand a little bit of the landscape surrounding stigma around opioid use disorder and substance use disorder, and then in particular with that health professional lens. So to start, stigma, what is stigma? Stigma is a mark of disgrace that's associated with a particular circumstance, quality, or person. And what it really is it is a barrier in a lot of ways to receiving healthcare, to actually, partaking in help-seeking behaviors, which is hard to do even when you're not feeling stigma. And it does result in discrimination and exclusion. What we learned at Shatterproof when we did our first initial jump into this space is that stigma is a driver of 7 of the 9 key drivers of the opioid epidemic, of the overdose epidemic. So we're looking at shame and social isolation. So for those who have a substance use disorder, it really reduces a quote unquote whole person to somebody who is quote unquote broken. And this is the language that we hear all the time. And it can result in, little or no self-esteem, people not willing to associate with people with a substance use disorder. I think all of us who had a tough time with the stay-at-home orders early in the pandemic now really understand the difficulty that social isolation can pose for us and our mental health and well-being. It also drives people not seeking help for their substance use disorder, like I previously mentioned. It gets codified into policies that result in insufficient treatment capacity. We see it codified in lack of healthcare coverage and reimbursement disparities. We certainly see non-evidence-based treatment and recovery mechanisms out there, an overcriminalization of people with a substance use disorder, and all in all, it is a social and structural barrier to recovery from a substance use disorder. So there are a few different types of stigma. There are, public stigmas or individual stigmas, which is, our negative attitudes as a society and as individuals towards a group of people, in this particular case, people with a substance use disorder, that creates an environment where people feel unwelcomed, judged, blamed, isolated. Structural stigma really manifests as policies, institutional policies, or dominant cultural norms and narrative that, reinforce stigma. And then lastly, we have self-stigma. And in this particular case, we're talking about where people really accept those judgments from societal and structural level stigmas in people, and they accept that and they internalize it, right? And it results in, reduced self-esteem and reduced self-efficacy. So this is where we're starting from, right? It's very, very clear that there's different types of stigma. There's also stigmas against medications for opioid use disorder, a topic with which you are all familiar. But then to really bring it home, it just manifests in this broad world of barriers where people can't seek help if they need it. So when we first started this process, right, we're like, how do we actually measure stigma reduction? And I'm talking a little about this today, in part because we learned interesting things about healthcare professionals from this index work that I'm about to talk about, but also because it's very important that we actually evaluate our efforts. Do we know if attitudes that, stigmatizing attitudes are being reduced by our campaigns, by our education and awareness events? Do we know that by changing our language that it increases the quality of patient care? This is important things that we have to measure to make sure that we are truly helping those who have a substance use disorder and their loved ones. So to do that, we developed the Shatterproof Addiction Stigma Index, which is a first of its kind measurement tool that we developed with the Indiana University and the global marketing firm Ipsos. It's designed to assess attitudes about substance use in people who use substances from the general public, as well as healthcare professionals. I'm happy to talk more about this later, to get in contact with anybody who has further questions offline. But what this does is it utilizes indexes or indices, which is a measure of change that uses representative data points to really look at those three buckets I mentioned earlier: public, structural, and self-stigma. It enables us to set a baseline to say, hey, this is where we were, this is where we are now. Let's correlate this to what we've been doing to move the needle. And it utilizes a vignette strategy, which really enables a view of how stigma can vary by substance type, by recovery status, etc. And I wanted to really incorporate this a little bit here with this audience of a lot of healthcare professionals, because what we did is we took the diagnosis for a substance use disorder from the DSM-5 and created a scenario, a vignette in which a person had all of those characteristics, but we never used the word addiction and we never used the word substance use disorder, because we wanted to really get at these intrinsic biases about people who use substances. So the key takeaways that we found here are 5. 1, that less than 25% of respondents view substance use disorders as the chronic disease that they are. 2, that over half of respondents still hold beliefs that substance use disorder is caused by bad character or a lack of moral strength. 3, that almost half the public is unwilling to live next door to or be close personal friends with somebody with a substance use disorder, back to that social isolation point. We also learned that stigma persists even when somebody is in long-term recovery, which was very disappointing to find out. And lastly, we found out that over 40% of respondents viewed medications for opioid use disorder simply as substituting one addiction for another. In particular, like I mentioned, we did oversample healthcare professionals. And what I wanted to call out here is that we saw similar or higher levels of stigma associated with substance use from healthcare professionals in comparison to the general public. So we are seeing that 65% of healthcare professionals, don't believe that substance use disorder is a disease. These numbers up here are something that are very clearly a concern given the level of interaction that healthcare professionals have when helping somebody with a substance use disorder, supporting their families, etc. So real quickly, I just wanted to highlight a couple of ways that this actually manifests in clinical practice, just to kind of bring this home. So for example, I said, 2 out of 3 healthcare professionals believe that substance use disorders, isn't a chronic disease, right? And it's created, very much treated as like this acute state, right? That's associated with moral failing. And part of what we have to do here is really drive home that substance use disorders are driven by genetic and environmental factors, and that the rates of recurrence or relapse are very similar to other chronic diseases. We also know that we now know that, you know, stigmatizing language in medical records has led to outcomes such as decreased treatment of pain. We now know that residents also have more negative attitudes comparison to medical students, which truly suggests that stigma in medical culture serves as negative reinforcement over time. This may, you know, in fact, also be related to said, you know, negative medical terminology. And then lastly, you know, I just wanted to mention, you know, when the healthcare system is a result of, you know, decades and decades and decades of systems and policies and procedures, which is exactly what it is meant to be. However, when this was created, substance use disorders were not considered to be a chronic disease. They were considered to be a moral failing. So we have to build from this ground up a new system that can really reinforce substance use disorders as a medical condition, because the system was not created to treat them that way. The good news is that attitudes towards people with a substance use disorder did improve after taking an online training module. And this is something that, you know, we were very, very pleased to see, and it really lends to like this next slide. Part of what this looks like is actually changing our language, right? And we're going to talk a little bit more about that throughout the rest of the webinar, but words really shape how we view people and how we treat them. What we found in one study that was conducted with over 500 trained mental health and addiction clinicians found that those who read a vignette that had, you know, the term person with a substance use disorder, as opposed to a substance abuser, the people who read the more person-centric language were more likely to refer to treatment and less likely to say that the patient was personally responsible for their illness and that punitive action should be taken. So we know this now. We know that changing language can help. So what we can say, you know, person with a substance use disorder, what people are going to use their language for themselves, and we should certainly never overcorrect them and say, well, you should call yourself this or that. That's not the business that we're in. But as general public and healthcare professionals, we should use the words person with a substance use disorder, you know, recovery, substance misuse, as opposed to addict or abuse or terminology such as dirty and clean. So that's just one example of how we can affect change here. I wanted to just say real quick that, like, this is a long goal, right? If we're trying to revolutionize the healthcare and treatment systems, we need our education and awareness. We need our individual knowledge and attitudinal change. And all of that together can lead to this organizational and systemic change that we truly need with the right systems in place. So now that I've kind of level set, I'm going to, you know, go to the panel discussion in just a moment, but I did want to highlight, you know, 4 stigma reduction opportunities before I do that. That looks at, you know, like I mentioned, using person first and recovery centered language, identifying and eliminating structural barriers, using sympathetic narratives, and we'll talk about this more in just a moment here, sharing patient stories. What does it look like to share a story? How does that help? And then, you know, for those of you who have more of an ops type role in your organization, you know, what can you do to incorporate stigma awareness and reduction trainings into the education for your staff? What does that look like? How can we advocate for that? So just want to leave you with those 4 thoughts as we move into the panel discussion and really look at, you know, some more of the specifics here. So thank you for bearing with me, and as I share my screen there. And I'm going to, you know, take a moment now to introduce our panel, which I'm very excited about. And I hope that everybody can, you know, come on camera now as I introduce you, because I'm very excited about this. Hi. So just to start, I'm very excited to introduce Dr. Danielle Anderson, who has received her medical degree from the University of South Carolina School of Medicine in Columbia, South Carolina. She completed her family medicine residency in the University of Kentucky Rural Track, spending her last 2 years of residency at St. Clair Healthcare in Moorhead, Kentucky. Dr. Anderson completed a fellowship in addiction medicine at the University of Kentucky and now works in the UK Department of Psychiatry as an addiction specialist addressing all types of substance use disorders. I am also pleased to introduce Jerrica Brandenburg, who lives and works in Estill County. She graduated from Eastern Kentucky University for her undergraduate degree and the University of the Cumberlands for her graduate degree. She's been in the field of counseling since 2015, during which she ran outpatient rehabs, sober living facilities, and currently does counseling and brief intervention out of the ED at a rural health hospital. She has also served on several local boards such as ASAP and helped organize media campaigns to end stigma. Lastly, I'm pleased to introduce Jessica Winchester, who is a 4-year survivor of substance use disorder, in particular opioid use disorder. She's a peer support specialist at Mercy Health Marcum and Wallace Hospital in the rural city of Irvine, Kentucky. Jessica struggled with alcoholism from a very young age of 12, which then led to the addiction of pain medication after an injury and later to being an IV user of heroin. 5 years ago, Jessica was living under the bridge in downtown Cincinnati, Ohio, and had not seen her kids in over 2 years and was on the verge of death. Jessica now owns her own home, is married, and has her kids back, along with some bonus kids and even grandbabies. Because of one nurse practitioner never giving up on her and always trying her best to lead Jessica in the right direction, she's able to work on the front line of addiction and help as many people as she can with her experience and life story. So again, I'm very, very pleased to welcome all of you here. Thank you for introducing yourself as well. All right. So with that, I think that we can kind of turn over to our panel discussion, if that sounds good to you. Wonderful. Thank you. All right. So with that, I'm going to kind of just start off with a broad question here for our panelists, and I invite y'all to just come off mute as desired, and we can certainly see, you know, who wants to kind of take this first question. But importantly, let's set the stage here a little bit. So why should we be talking about stigma within a healthcare delivery setting? We looked at this a little bit with what I was just talking about, but how does it permeate the system nationally and locally? And anybody just feel free to unmute and kind of pop in here. Dr. Anderson, if you'd like to start, I think that we can certainly use some, you know, some of that, answer a little bit of the question about permeating the healthcare system.
Sure. Stigma is very much alive in the medical community relating to people with substance use disorders, and it's really present at all levels. And this stigma, as you mentioned earlier, Rachel, it deters people from receiving life-saving treatments. And that, I think, is one of the main problems of stigma in and of itself. I find oftentimes when patients come into my clinic to be seen, they have not been to anyone to talk about their substance use disorders or even general medical care due to the fear of stigma that they won't be accepted, that they will be treated differently from other patients in the office. And it's causing, as you also correctly identified, an increase in the number of overdose deaths because people are afraid to seek treatment. I think that stigma is available at all levels, from the person that maybe admits the patient or checks in the patient at the front door of an office, to medical assistants, to medical students, to you know, our advanced practice providers, our attending physicians. And so it really takes a top-down approach to address this. And before we can effectively really get people in the treatment that they need, we've got to decrease the stigma so we can welcome them back into the medical community.
Jerrica, Jessica, anything to add?
Yeah, I want to add, Dr. Anderson touched on it, but she said, you know, stigma, even when they first walk in the door. That was a really big thing for me. Is, you know, there was a couple times that I would go into a clinic when I was in addiction because I had a really bad infection or something pretty life-threatening. And I would turn around and walk away because the receptionist just looked at me like, oh, there's another addict. You know, I mean, that's something that really needs to be taken in consideration, is that very first person that is seen is the receptionist. And if they have the portray of, you know, stigma, they're going to instantly start judging the person with the substance use disorder. They're automatically going to think everybody behind that wall is going to do it as well.
I would just like to touch base on what they both said and say that in my previous experience working in a lot of rural healthcare clinics, a lot of times it stems from maybe the receptionist's past history, even if it's private, with what they've experienced with people with addiction. And so that's why it's so important for the workplace to have open discussions and education to try to reduce the stigma. I've had many times when a receptionist, just because someone had alcohol on their breath, they would be like, should we call the police? And I'm like, no, a lot of times some of my clients have to drink the first time that they wake, or as soon as they wake up in the morning, in order to get here, because they go into withdrawals and they're not ready for that next step of treatment yet. So it's all about meeting them where they're at. And it really showed the kind of stigma that they had toward those people.
And I think I would just add on to that, that one of the barriers to really reducing stigma is that individuals have developed stigma for various reasons. It could be, as we just talked about, that they had a family member or a friend that that had a substance use disorder, and their experience with that person may influence how they feel about patients who are coming in wanting to be treated for substance use disorders. Similarly, they may have had a friend or family member or someone close who sought treatment and really did not necessarily benefit from treatment. We really need to ask everyone at each level, as we just talked about, from the person, the receptionist, all the way up to the provider, get them to look internally and say, what experiences have I had in the past that may be impacting how I feel about these patients? And I think that's actually where it really starts, is being able to look within and see what's shaping their thought process. Is it personal experience? Is it how they see other people in the office or in the hospital treat patients with substance use disorders? Is it a cultural thing within the entire healthcare system that they work in, where patients are not receiving the respect they deserve? So I think, again, the stigma exists, and immediately we have to look at what barriers they are to overcoming the stigma.
Thank you. I really, really appreciate that from all three of you. And there's a couple of points that I think we can kind of dive a little bit deeper into. So I would ask the question, so what does successful stigma reduction look like in the healthcare setting? And I want to take this from two angles. One is from the actual provider perspective. So from a provider perspective, what does successful stigma reduction look like? And maybe some of the barriers there, but also from the patient perspective. What does that look like from the patient perspective? How would that in theory manifest when you walk in the doors, when you're having conversations with a provider? Because oftentimes we think of these things as two separate things, but they have to be done in conjunction if we're really going to affect change. So happy to turn it over to whomever wants to go first on that. But what does successful stigma reduction look like, both from the provider perspective and from the patient perspective?
I can go first.
Oh, go ahead.
Go ahead.
From the provider perspective, I would say that successful stigma reduction, that really comes from the top down. As you identified, we're seeing that medical students, those are in training to be nurse practitioners, PAs, develop these biases very early in their training. And so to combat that, we need to start teaching the science of addiction, addiction as a chronic disease, addiction as a brain disease, and start that very early in their education, so they can carry that forward when they start to do clinical rotations or start working in the hospital. Because we tend to emulate the residents that we learn from, the attendings that we learn from, and while that stigma may already exist there, we can bring people in who are changing the perspective and the culture of medicine and how we think about addiction. I try in my practice, in a psychiatry practice here, where people are very open to talking with their patients about addiction. I try to model that when I'm in other settings for other physicians. I think that providers can model this behavior for their residents and for their trainees. And that's going to go a long way, is modeling the behavior that you're hoping the training will carry forward.
Okay. So just something I would like to add to that is I feel like that one of the most important components for the provider and the patient is empathy. I feel like that's not a word that's used enough in this area and in this field. The provider has to have empathy for the person that they're treating and, you know, realize they're not just a number, that they are a human being who has feelings, thoughts, emotions, all those things. And then also, you know, lots of times I do think that patient you have to open up their empathy, and that comes from like building that rapport back and forth with the provider and the patient. And I do think that what she said is really important about talking about how addiction is a disease. A lot of people on both sides of the fence are not open to that idea still. You would think that they are, but most of the time, you know, they're not. And some people just have never been talked to about it. So one of the things that we really tried to hammer home when we had a Hep C clinic going here at the hospital is I really tried to educate them on, if I know that I have diabetes in my family, I probably shouldn't go to McDonald's every day. I probably should try to make healthier choices. And I kind of talked to them about that starting at a young age. And then if you're older, making choices based on that. So a healthier diet for your liver, all those things. And then also reducing your use. We're going to talk about a question later on down that I think will feed into that same concept. So I just wanted to build on that.
Jessica, did you have anything you wanted to add?
On a patient's side, when in my bio, you guys read about a nurse practitioner that never gave up on me. She was not very open at first. She kind of did have that outlook on the an addict's never going to change type thing. She had the stigma, but the closer that, like I said, the closer she got to me, but when our relationship got stronger and she realized that I was a person, like, you know, like Jerrica said, the empathy opened up, the barriers got broken. She realized that this was not something that I chose for myself. The stigma started to drop. The stigma in the whole clinic started to change. I was no longer just that troubled patient. Now I get to work with that nurse practitioner in one of the clinics here, which is awesome. And I thank her all the time for not giving up on me. But she also knew when she had to be firm with me as well. She knew when I did want to get lectured, or when it was good to lecture me, when it wasn't a good time to lecture me. But she also later told me that, you know, she did a lot more research, because I was one of those patients that had medical problems outside of addiction, but I also had addiction. And so she really talked to some other people, seen how they handled situations like that. And now it's great. I mean, there's a couple times she yelled at me, she opened my eyes, but she never gave up, and she never done it in a hateful way. Like, she always had loving intentions behind it.
Thank you for sharing that. And to echo some comments in the chat, Jessica, thank you for your vulnerability today and for sharing your story. It truly lends such quality and such insight to this webinar. So thank you for that. I wanted to talk a little bit. I mean, we've touched on this a lot, but I think it's not a bad idea to really spell this out explicitly. What are the biggest challenges to supporting substance use disorder patients in the healthcare setting when they try to receive care? And the answer to this could come, you know, in multiple ways. You know, Jessica, again, to your personal experience, or Dr. Anderson or Jerrica, what does it look like? You know, is it lack of coverage? Is it a referral system that needs to be fixed? What does it look like? What are the biggest barriers for when a person with a substance use disorder is trying to receive care? And this may be anecdotal from your own personal experiences, or more broadly speaking on a state or federal level as well. whoever wants to hop in can go.
I'd really like to build on what I said about the empathy and building rapport. So, not just in a counselor perspective that I come from, I know that Jessica also uses this perspective of building rapport, and I'm sure that Dr. Anderson does too. But so I work in an ED setting a lot here in the hospital, and one of the big things is nurses, doctors, anybody else who comes in contact with the patient really has to try to build that rapport first, because if they don't, most of the time, that patient is not going to tell them the truth. And knowing exactly what has happened, I feel is critical to us being able to treat the person properly. So just trying to break down, we are here for you and we just want to do whatever we need to do to help you. We're not here to judge you. We just want to help you and save your life. And this is a life-threatening issue. Even if, drugs in general and addiction is a life-threatening issue, and just reiterating that. So I feel like rapport and empathy, transparency and trust and caring. I've read a lot of leadership books in the past, but I feel like it really transcends just leadership. Everybody wants to know that they can trust their provider, that their provider cares about them, so the empathy, and that there is transparency. And so I feel like when you walk in a room and you level with a patient and talk about being there for them, if you do not do that, it's one of the biggest barriers to care from my perspective. It's the difference between somebody else going in and not getting the whole story and me going in and getting most of the story when we're all working together.
So I would say several barriers, and I would just echo saying quickly building rapport with patients so that they can trust that you have their best interests moving forward. It is a huge barrier, and sometimes it's not possible to break that barrier and build that rapport because of how patients have been treated in the past by other people in the healthcare system. So that's one of the skills that we really need to teach our counselors, our social workers, our medical students, our PAs, nurse practitioners, our nurses, is how to build that rapport. Unfortunately, just the setup of the healthcare system is, see as many patients as possible during the day. And these conversations and building rapport, they take time. And there's really not that time built into a lot of, primary care providers' schedules where they can have, an hour-long conversation that really needs to be had. It's a barrier to building that rapport and really starting crucial discussions with the patient. Another barrier, insurers, again, prior authorizations for life-saving medications have been issues with that I've encountered in the past. Also, getting insurance to cover the level of care that a person needs, whether they need to do an intensive outpatient program or whether they need a residential treatment program. Recently, I had a patient who wanted to go to residential treatment and was very, very motivated, and it took over 21 days for this to be approved by insurance. Most people don't maintain that same level of motivation for 21 days after they've gone through a medically supervised withdrawal. So, that's something that I'd love to say that cannot happen anymore, but it is happening and it will happen. And that's the biggest, I think that's the most difficult thing that I deal with, is that a lot of what I am doing for patients is trying to call around, match treatment plans and insurance. I have some wonderful, wonderful case managers that work with us, but it takes all of us making phone calls, doing letters of medical necessity to find the right level of treatment for this person, and then maybe find out that, hey, insurance is only going to pay for them to go for a week or two. So it's very frustrating. I think it's frustrating for all involved, and maybe why it's not addressed as much in certain medical settings, because they don't have the manpower or the resources to make all of these connections.
That makes a lot of sense. Jessica, I wanted to give you an opportunity to answer the same, but I want to actually kind of add a question on that you might have some insight into, having been a patient yourself in this particular instance. And then I would like to swing it back to Dr. Anderson and Jerrica as well. But can you talk about, what mistakes clinical staff make when they're trying to build rapport, like how that does not work, some of that conversation as well. Jessica, I think you might have some interesting insight as you finish answering that more broad question about, the biggest challenges.
Yeah, so some of the biggest challenges that I'm facing now is the patients, kind of like Dr. Anderson said, the patients want to go at first when they first come out of that overdose and they're scared. But you wait 10 minutes or 15 minutes or an hour to get in touch with the rehab that's going to take their insurance, and they've already changed their mind and they're leaving. So that's the insurance thing is a big deal, especially if they are one that maybe went to a facility within the past 28 days. A lot of insurance does not want to pay if they've come home and relapsed, and maybe not necessarily want to go back to inpatient, but they want to do IOP. They want to do some type of aftercare that's going to cost them. The insurance don't cover it. There is some programs around here that we're able to get them into that don't cost, but not everyone has that. Not a lot of counties has that at their fingertips. So I know that is a big barrier. As far as the some of the mistakes that clinicians make is, I think they sometimes have the idea of they have to watch how they handle their patient, like how they handle an SUD client or patient. I don't think that it is, I think if you act more like yourself, you act like you are just a human, you don't try to push your doctor title around per se, that makes them realize that you are kind of on their level. Like if, for me, for instance, I was at one doctor's office years ago, before I got with the nurse practitioner I was referring to earlier, and they pretty much was like, I understand addiction more than you do, and this is all you have to do to stop. And that's not real. I understand that, a lot of doctors do understand addiction really well. I know that even more now that I'm working with a lot of them. But at the same time, there's still some that just really think that you can just quit and it's that easy. So that's kind of what I would say would be the biggest mistake.
Dr. Anderson or Jerrica, do you want to add anything on to kind of like the biggest mistakes that you see when trying to build rapport? Anything that you wanted to add there?
I would say for anybody wanting to build rapport, you have to be able to read the room and understand that that rapport may not be built completely in that first appointment. And the goal is for you to build enough rapport so that patient will come back. I think one of the mistakes people make are just piggybacking a little bit on what she said, is not involving the patient in the medical decision-making process and saying you have to treat addiction this way, you have to do number 1, 2, and 3, you have to do these things all in a row, you have to attend AA meetings, or and that's what you have to do to become sober. And addiction treatment should really be individualized based on the patient's needs. And so I think that providers sometimes do say, you've got to stop this and you've got to stop now. But the question you should be asking the patient is, what is your goal? Is your goal to reduce your use? Is your goal to completely stop using? And starting with that instead of the agenda of the provider. I do think it's important to have those important conversations about the fact that continued use may result in death, may result in overdose, may result in another chronic medical issue. But the most important The most important thing a provider can do is assess what that patient's goal is and then help them create a plan around that goal, rather than the former way we used to have these visits in medical care, where there's a very paternalistic approach. We need to involve the patients in the shared decision making.
I think that everything both of them have said is pretty spot on. The only other thing that I would add is, from a clinical perspective, one of the biggest mistakes that people make when they're trying to build rapport is to self-disclose. So I just thought I would mention that. While it's okay on the peer level, because usually that's what they're taught to do, is to self-disclose their personal recovery story and how they did that. From a clinician standpoint, most of the time you don't want to do that. But one of the things to build empathy is to build rapport is to build empathy. So just hearing what they're saying and rephrasing that back to them and making sure that you are hearing them correctly. So like, am I hearing this, or this is what I'm hearing, and making sure that you're getting the correct perception, and they'll correct you if you're not saying, what you're hearing back correctly. And I just think that helps a lot with empathy.
That makes a lot of sense. Thank you all for sharing your perspective there. There was a question in the chat. I think we're going to turn to some of those now. We're in the Q&A. I mentioned this earlier when I was talking a little bit about the data that we've seen, but how do you, the three of you, combat the perception that medications for addiction treatment or medications for opioid use disorder, how do you combat that it's not just a different addiction, that it's actually a treatment? How do you go about that? Because that perception shows up a lot, both in the general public and in the healthcare profession, that MOUD is simply substituting one addiction for another. How do you combat that?
I like to use this example, and this is why I've tried to kind of answer my questions to build a story throughout this. I don't know how many people here know what Prime for Life is, but it's the curriculum that you use to teach people who have DUIs, which could be from alcohol or substances. And I say the same example because that curriculum teaches it, that just like diabetes and how those people need insulin and certain things to get better, that is how I form MAT or anything like that to the patient, like trading one thing out for another. If you present it as a disease and you're like, this is the treatment for diseases, there would be no reason why we shouldn't use a medication or some type of therapy, some medical treatment for this. And I also use that for your risk factors and all of that. Just, I think that using another chronic disease and relating and comparing, I think that helps.
I absolutely agree with that, both on when talking to patients and family members and with other providers and other people in the healthcare system. I also like to, many of us in the healthcare system, we're into the science and the science of disease pathology. And that's where I like to go to talk with other clinicians about these medications. Buprenorphine, which is commonly used to treat opioid use disorder, as many of you know, it's a partial opioid agonist, whereas our pain medications are a full opioid agonist. And so basically the function of buprenorphine is to fill those opioid receptors up a little bit, enough so that the person doesn't experience withdrawal symptoms, which are a major driver of returning to use day after day. And it also prevents development of cravings. I like to talk about addiction as a brain disease and how those triggers like cravings and withdrawal set off an entire cascade system in the brain that drives someone to pick up that substance again. And it doesn't take very long to describe it. I could talk to a clinician about this in 2 to 3 minutes. And sometimes when they understand how the medications actually work, it decreases the stigma around using those medications. When patients, sometimes the stigma actually gets to patients and they want to come off these medications because of how other people feel about them. Buprenorphine is a legal medication. It's obtained by a prescription from your doctor. It's not something that you bought off the street. It's not something that is a product, a mixed product with several different illicit substances in it. It is a prescription obtained by legal means. And sometimes that can help reduce the stigma in the patient's mind or another provider's mind that this is a very controlled situation that we're in. It's not illicitly obtained.
Thank you. Jessica, anything you wanted to add to that?
I'm a little different about that for this, just for the simple fact of I have used both for good and bad. My personal opinion on this is they are great. They are a great thing if they're used correctly. But I feel like some places do not. I don't think that they maybe monitor them very well. And because of that, that's where a lot of the stigma comes from. Because you have those that will be on, you know, like, I don't know the actual medical terms for Suboxone, but like I think they will go and they'll get them from their clinic and then they trade them for something else, but yet they're going around saying that they're on Suboxone. However, the community sees them still at the drug dealer's house. That's where a lot of the stigma comes from, is because so-and-so's mom's saying, you know, little Johnny's doing good. He's going to the Suboxone clinic, but yet little Johnny was passed out on the side of the road, overdosed the night before. You know, there's good and bad in both of them. I think it all depends on how the provider is monitoring them. I think they're amazing for withdrawals, but I don't know that maybe they need to be such a high dose for such a long time. Like even with, you know, like Jerrica mentioned the diabetic thing, you don't start off at the maximum dose of insulin. You have to find out what works best for that person to where they can still live a life and not let the diabetes control them. A lot of places don't do that with some of these MATs, and that's where the stigma is coming from. I know a lot of times when you're pregnant, living up in Cincinnati, I had a friend that was pregnant, went to a methadone clinic, and she was higher on methadone all day, every day than I was doing heroin. But yet she got to come home with her baby because she went to the methadone clinic.
Thank you so much for that insight. We just have a couple minutes left, so I do want to continue. I have one more question, and then I think Danielle or Dr. Anderson, I saw that you came off mute there for a second. So if there is something else you want to add, feel free. But I just want to be cognizant of time. So
just briefly, I just wanted to say that absolutely the quality of care is really, really important. And I think that there continue to be some more regulations surrounding methadone and buprenorphine to help ensure that they're not misused, but absolutely quality of care and the quality of the care provided in the clinic and support services are very important.
Thank you. So I think we're going to close here, well, not close, but kind of move towards closing because this is kind of a longer question and I want to make sure everybody has a chance to answer it. And I'd like to talk about some of the advice that we can give audience members, because we've had a few questions come in about this. So if we could do 3 pieces of advice, you know, one piece of advice that you would have healthcare professionals leave with today, one piece of advice for wraparound services, so people who are here who are working in healthcare adjacent fields, what makes the most sense from your perspective, how can they help best? And then just a piece of advice for anybody who is supporting a loved one with a substance or opioid use disorder. I can repeat that as we go through, because I know that was 3 things at once, but whoever wants to go first to give a piece of advice for healthcare professionals or an action item, a piece of advice or action item for people who provide healthcare adjacent or wraparound services. And then lastly, for somebody who's supporting a loved one with a substance use disorder.
I can go first. I had replied back in the chat to somebody when I
Mhm.
saw, but basically there's this will be for anybody supporting, or if you want to break the stigma or just try to support breaking it. There's a wonderful TED Talk. I think that everybody in this field should watch it and share it. It is about the Rat Park study. It was done, I think, in the 70s or 80s. And a guy basically, he goes over that. I won't go in depth. He also talks about what somebody could do if they love somebody who is in addiction, but without enabling them. And he talks about what some other countries have done. And they've kind of stopped their war on drugs, per se, which we are kind of growing out of, and shifted to a supportive model. And they found that that works better. And then I would just say for healthcare, that I really believe in a holistic approach. So anybody who knows what the Cherokee model is, I know not everybody's in a healthcare setting where they can do that, but I highly suggest working with somebody where you can work with peers. You can try to work with a practitioner or a doctor or a nurse practitioner to make sure that you're hitting every area that that person needs. So their chronic disease management, their emotional resources, and then their life management. So case management resources and things like that. Having all of it is integral to somebody's recovery.
Thank you. Dr. Anderson or Jessica?
So my piece of advice for those who are working with the people that have substance use disorders, it is very hard. It's hard at times to combat all of the stigma around you, and also just can be mentally taxing trying to find treatment for people that works for both the patient, the insurance, and that that they're able to do. So I would say we always have to check on our resiliency. If you find yourself internalizing some biases, try and go back to thinking of addiction as a chronic disease, that this needs to be treated like we've talked about, like hypertension, like diabetes, and take a step back if you feel like you're getting frustrated in the field. For people who are caring for those with substance use disorders, family members, friends, you have to know your boundaries. You can be a support person if it's somebody close to you, but you also have to be able to establish boundaries. And I definitely recommend looking at support programs such as Al-Anon, and finding other people who are trying to support someone else in recovery as well. And then what was the second one I think I missed?
Just a piece of advice for people who provide wraparound or healthcare adjacent services in particular.
Okay. For people who provide wraparound services, I wish I had some great advice, but what I would say is, again, the resiliency piece. I know that it's difficult when you're working in a system that may feel very broken at times. The other thing I say is get involved in advocacy and you're at the state and federal level so we can start improving access to care for patients. The squeaky wheel gets the grease sometimes.
Awesome, thanks. And then Jessica, would love any words of wisdom from you before we turn it back over to Michelle.
My advice for the clinician is, and this might sound a little crazy, but make sure that you're taking care of yourself and you're up to par with yourself. Because when you get burnout or you see that same patient, like for us, we work in an ED, so it's not like, our doctors have a set patient and they're going to see him a set time. But when that same patient comes in 3 or 4 times in a month with the same exact problem because they've overdosed and you're having a bad day or you've not been taking care of yourself mentally, you're going to snap at that person and there goes the stigma. As soon as that happens, that doctor went off on me and they shouldn't have done that, and that's all around town, and then there it goes, like rumor mill, full course. So that would be my biggest thing. As far as the wraparound,
yeah, it's a hard one.
It is a hard one.
It is a hard one.
We stuck our chaplain in the office with both a peer support specialist and a therapist, so he knows firsthand what we both deal with daily. Maybe they can spend more time with some of the clinicians, get to know some of the backstory on some things, definitely do some research. That's probably the best advice I could give on that one.
I think it makes a ton of sense. Those community partnerships are so critical to success, to supporting the full person through their treatment and recovery journey. So thank you so much, Jessica, for that.
Thank you.
Michelle, I'll turn it to you.
Thank you so much. And I want to thank everyone who's still here with us. I know we're coming up on time, but a very quick thank you to all of our panelists, Rachael as being our moderator. This was a fantastic conversation. I was trying to keep up with the chat and responding to the questions for our panelists, as well as those sent through the Q&A. But before we wrap up, I just wanted to go over a few additional resources for folks. I'm including in the chat a link to the Shatterproof Addiction Stigma Index. This is once again an incredible tool highlighting the different perceptions held by public, employers, healthcare professionals, as well as those with substance use disorder. And I think it could be really interesting for those who are working in the field and others curious about how their own biases or perceptions may present themselves in their communities or everyday lives. As well as a reminder of our upcoming webinar for the month of August. We are promoting a Rally Around Recovery month activity. So this is going to highlight our campaign partners within Kentucky, give them an opportunity to present on their work, any events that they have going on related to Recovery Month in September. Just an opportunity to shift the spotlight back onto them and the people doing this work. So I want to thank you again for participating. If you have any follow-up questions, please feel free to reach out and visit us across our social media channels, as well as the UNSHAME Kentucky website. Thank you again to our partners at the Kentucky Hospital Association, and I hope that you all have a fantastic day.